So this is Norse Foundation's frozen shoulder video to give people an overview of what frozen shoulder is all about. So here we go. So obviously you can see a lovely picture there. It's caused by thickening of the joint capsule, which results in a painful arc of movement and often a massively restricted arc of movement. The passive and active range of movement is significantly restricted. The etiologies, or the causes, which can trigger the condition are as follows. So it says here supraspinatus tendinitis, infraspinatus damage, first rib dysfunction. The shoulder itself there, you can see from the picture, you can see a normal shoulder and then you can see the sort of scarred version of the frozen shoulder. Inflammation around the joint causes the tissue to become dense. The folds of the capsule will not move properly and so the range is removed dramatically. This is very much a downward spiral. The capsule then develops scar tissue and reduces the space between the acromion and the head of the humerus. So basically those folds in the shoulder joint cease to flex and slide across each other, and it obviously gets very, very stiff and difficult to move in there. Frozen shoulder. It's more common in people over the age of 40 years old. It's more common with people who suffer from diabetes. Women are more prone to it than men. In active people, sometimes there's no apparent reason for the start of the condition, and some poor people get it in one shoulder, recover from it, and then in a short period later get it in another. The traditional medical treatment varies. In mild cases, exercises and analgesics, so your non-steroid anti-inflammatories, steroid injections obviously, and in extreme cases they can use some kind of surgery to remove the scars. But what they do these days is that basically they fill the joint up with water to break apart some of the scars, and that is generally quite effective if followed up by good physiotherapy. It normally lasts for 18 months to 2 years. There are 3 classic phases: the acute inflammatory phase, the stiffening phase, and the thawing phase. It is truly an unpleasant condition if you have ever had it, and to be avoided. When assessing frozen shoulder, the therapist must consider the following things. So you'll do all the usual orthopedic tests. There will be a significant loss in range of movement, especially in abduction, flexion, and external rotation. Frozen shoulder and bursitis appear very similar, but in bursitis there will be a painful in all movements, whether passive or active, and compression of the joint will cause extreme pain. Frozen shoulder will have a restricted arc, but will have muscular strength in its range in isolation. The arm is abducted. When the arm is abducted past 80 degrees, they will move into flexion. This is because when they move into flexion, the greater tubercle comes out from under the acromion and will thus give a greater range of movement. We'll talk about altered scapular rhythm here. So you can see the normal arm and then the bad arm. In flexion and abduction, when they are reduced, the subscapularis is hypertonic, causing teres minor and infraspinatus to they can't rotate the shoulder properly, and therefore what happens in a healthy shoulder is that the medial pull of the subscapularis is balanced by the lateral rotators. And what happens in this case is that because that is not the case, you get an altered scapular humeral rhythm. So the scapula should move 1 degree for every 2 degrees the glenohumeral joint moves. But in this case it doesn't, and so you can see that in trying to flex or abduct the arm, the patient lifts his scapula to try and get extra range of movement. It is a classic telltale sign of frozen shoulder. So treatment for frozen shoulder is complicated. So obviously exercises and analgesics to reduce pain and maintain what movement you have. Steroids are good in certain situations, but you don't want to use too many of them. In extreme cases, as we've said, basically you can go in and have surgery to reduce the thickening of the capsule. Manual therapy, which is where people like me come in, is used to reduce pain and increase range of movement. It is very effective for most people, but it does take some time. If we then look here, there are classically 2 different subcategories of frozen shoulder. So you have a capsular lesion and a non-capsular lesion. Now, If you look on this side over here, the capsular lesions, to be quite frank and honest with you, they are all the unpleasant things, right? So everything from, basically forms of cancer all the way through to the results after dislocations. The capsular stuff is very difficult to treat, requires other medical interventions normally, and is complicated and not very nice. But then on the right side over here, you've got the capsular lesions, which we can treat very effectively. And they normally start with an itis. So you've got supraspinatus, tendinitis, subdeltoid bursitis, so on and so forth. And the point here is what classically happens is that somebody will go and do something like chop down a tree. They'll give themselves supraspinatus tendinitis. They'll then chicken wing the arm against their side for weeks and weeks and weeks and weeks because it hurts because of the tendinitis. And then as a result, they end up with full-blown frozen shoulder because they haven't moved it. That's why early movement in so many of these injuries is so important. So, summary, caused by thickening of the joint capsule. It's a painful arc of movement. Passive and active range of movement is significantly restricted. Linked to diabetes, heart disease, shoulder trauma, inflammatory disease, hypothyroidism, all sorts of things. Common in middle-aged women particularly. Often affects the non-dominant arm. Tissue becomes dense, fibers thicken in the fold of the capsule. The capsule becomes short, preventing external rotation and restricts abduction. And it can last, if untreated, 2 or so years, and it's broken down into 3 phases. I hope this is helpful, and good luck.